तो इस बस है mujhe allora no una giorno di bar su una banda
स्क्रीन शेयरिंग एनेबल करो सर डॉक्टर गुप्ता हेलो
yes sir done Samir
okay so we are back at few more examples and actually I am towards the end of the talk. This is internal memory artery visualization in echo. So the best graft to the coronary arteries is internal memory artery, and actually you can see it from left suprasternal supraclavicular view, so to say. And of all the of all the arteries in the body, the only artery which fills up in diastole are the coronary arteries. Rest all other arteries fill up in systole. And that is the reason when you are able to see LAD, which is, or internal memory artery, which is supplied to a normally flowing LAD, you'll have a diastolic augmentation. This is diastolic augmentation, which on exercise further increases. And this, if your internal memory artery is functional, rest assured the patient is reasonably fine, because the event rate of getting involved by any other arteries is so safe that if your LAD is well protected with internal memory artery, you are very much comfortable. These are last few slides which I just want to show you. These are dramatic slides because in coronary artery disease, we use it to monitor ischemia during surgery, intraoperatively, graft adequacy, graft patency. We see it all the time. Not only that, we see during surgery something known as path, which is protruding atheromas. And here is an example of protruding atheroma. And this is an example of protruding atheroma during surgery. So if you look at the date, this will be March 1996. This is a very old slide. And in 1996, we had this where we were telling to the surgeon that, listen, we are seeing something very nasty in the aorta. And he said, what is it? And he said, don't know, but it is something nasty, whether it's a thrombus, it couldn't be a thrombus, because aorta, how can aorta have a thrombus which is flying so much? And then he put in this is the cannula for going on the heart-lung machine. It exactly hit it at the place where there is, but fortunately it didn't fly off. So this is known as protruding atheromas. They can be very pliable, they can be very, very plastic, and they are very firm too. It is something like infective endocarditis. Till such time there is an active infection, these infective endocarditis vegetations, they have a tendency to fly off. But once it becomes sterile, then these become so plastic and flyable, but they hardly ever, because then the fibrosis element is too high. Similarly is the case for protruding atheromas, they hardly ever fly off. So these have their own implications, unexplained stroke, emboli, but whatever it is, these are to be. Now, there are certain surrogate markers of coronary artery disease. And these surrogate markers are carotid intima medial thickness, very easy to do. Cutoff is 0.8. People can debate that for Indian 0.9. For Indians, it should be 0.8 or 0.7, but it is very easily doable. And second is that you can see for the brachial artery flow-mediated vasodilatation and check for endothelial dysfunction. So this is how you check for carotids. Carotids are very easily seen. You have to have a linear probe though for that. And if you can see this, you can measure the thickness, and these are surrogate markers. For brachial endo, what you have to do is tie it and create some kind of a vasodilatation. The moment you release it, you see what is the dilatation like. If it is greater than 20%, you are comfortable. Greater than 50%, you are very happy. Though it has never seen light of any recommendations to be done or guidelines that for sake of prevention or early detection of coronary artery disease, flow-mediated vasodilatation or carotid intima medial thickness should be done. But these are things which are available, and you use echo in emergency room to detect site and size of infarction, assess prognosis, cardiac defects, cardiac complications, and effect of therapy. So thank you very much. I'll be happy to take any questions, and I'll stop sharing my screen here, or in case there are anything, please go ahead.
Can I ask a question, sir, Dr. Vinay?
Sure.
My first question was that at the outset, you said that wall motion abnormalities, they have a more of a negative predictive value. Means if it is normal, it essentially rules out.
A significant MI.
Yes. And if it is positive, then it is only 50% positive predictive value.
For acute MI.
Right. What is the reason for this?
Because wall motion abnormality presence could be because of old infarcts. So acute MI, if it is there, then you don't know, because most of the time, that's the reason the predictiveness improves if you have had an echo done within 3 months prior to the present one.
That means if we have an enzymes also simultaneously raised in a higher level, and we have...
Enzymes are, this is regardless of enzyme. If enzymes are raised, then certainly there is an MI.
My second question is that if we code with EF, so if a patient has a symptom, has a chest pain, putting all the things together, and EF is around say 40%, and there's a wall motion abnormality, then we are reasonably sure that okay, this might have been an acute event.
Correct.
But then the most of the challenge comes when the patient has a chest pain. We don't have a gross STT changes in the ECG. There might be some STT changes, and EF is mildly less. It may not be 40%. It may be something like 14-50%, as we said by definition of EF, by a definition of electrical functional dysfunction. So don't these people, aren't these patients a challenge for us, because they are the ones whom we are likely to miss?
So be dependent on, if ECG is non-diagnostic, your echo shows wall motion abnormality, get the enzymes done.
So if enzymes are there, that's a fresh thing.
Oh, certainly. And repeat the enzyme. In case enzymes are normal and you are pretty much sure on your clinical grounds that it is an acute coronary syndrome, observe them and repeat the enzymes in 3 hours or 4 hours. Because enzymes take almost 2 to 3 hours to start rising, troponins, especially.
And wall motion abnormalities appear before the enzymes are rising.
Yes, sir. But presence of wall motion abnormality. Now, I know where you are coming. You are coming that based on ECG changes being absent, clinical symptoms of acute coronary syndrome, presence of fresh wall motion abnormality.
Right.
Should you take the patient up for revascularization by thrombolysis or by PCI? Is it?
Yes, sir.
No, you should not. Because guidelines have been very clear that if the ECG is not showing signs of ST segment elevation. So there are three three ECG changes which govern thrombolysis or stenting, primary PCI. One is fresh onset of bundle branch blocks. Second is ST segment elevation in congruent leads. And third is, even if there is an ST segment depression in V1, contralateral changes. So which you are saying that if there is a tall R in V1, so that is a posterior wall infarct. So posterior wall infarct is an example of exemption. So of ST segment elevation, except for these three things, if you don't have anything, no matter what your echo says, you are not permitted to thrombolize the patient or that take the patient for PCI, unless he goes into a cardiogenic shock. If
But
he goes into a
Samir,
cardiogenic shock or if he goes into an arrhythmias, that is the time when you are permitted to take the patient up for thrombolysis, not thrombolysis, but PCI.
intervention. But important issue is, Samir, like number of times this RBB and LBB, they are seen now without any coronary involvements, acutely.
Correct. So RBBB is more commonly found than LBBB. So fresh onset of LBBB was an undisputed reason for revascularization in a clinical setting of acute MI. In a clinical setting, that was the caveat. But off late, not off late, 2018, when the European guidelines changed, then they included fresh onset of RBBB also.
And many diabetic patients, we are seeing now fresh onset LVB with normal coronaries. Even that is...
So that is the reason why they have introduced that caveat in a setting of acute coronary syndrome.
Right.
If you don't have a clinical setting of acute coronary syndrome, you have no business to revascularize.
And second important issue is what they should understand, that thrombolysis versus intervention should be on a basis of ECG, whether it's ST elevation or ST depression, not on the basis of echo alone.
100% agreed.
So another point was that post MI, we say that for 40 days we don't do any PPI or we don't do any like I had somebody had called me from Ranchi that patient had an acute episodes of syncope and fall, which was witnessed. But everything came out to be normal. Holter, everything was normal, and even tinnitus was done, it was normal. And finally, they decided to go for an angio first. The angio found that he had an RCA which was blocked, and they had stented the RCA. But even after stenting the RCA, he had these episodes of syncope and fall, and there was no documented heart block in any of his ECGs or any of the Holters. So the question came whether this patient needs to be put on a permanent pacemaker to alleviate his symptoms of syncope and fall, which were witnessed, which were generally fall. There was a fall in the blood pressure, there was fall in the pulse also, but by the time the ECG was done, there was nothing, and Holter never picked it up, done twice or thrice. They didn't have a facility of an ELR over there, so that's the reason why it was not done over there. But when the question came about putting a PPI, since the stenting had been done just a few days back, so they said that no, it won't be able to do it for next 40 days or it has a bad prognostic outcome, which also you pointed out over here that post-MI PPI or a defibrillator should not be blessed for 40 days. Is it simply because there's a chances of fibrosis or there's a chances of thinning out of myocardium and it may be perforated? Since we are putting a lead over there, that's the reason why we are not doing it for 40 days?
I never said about PPI. I only mentioned about ICD.
Right, sir.
Because PPI indications are in an acute myocardial infarction. They are very limited because it's only acute inferior wall myocardial infarction which leads to complete heart block, and these have to be documented. You put the patient on temporary pacemaker, and if the person is continuing to have complete heart block after 14 days, you have to wait for 14 days before you start planning for a permanent pacemaker. ICD is different. ICD is, if you look at the MEDIT-2 trial, they said that if the person has got ejection fraction less than 35%, these people have a higher chances of going into VTVF. And that's the reason why it is recommended that for anybody who has got less than 35% ejection fraction, start considering ICD regardless. Except that in an acute myocardial infarction situation, you do an echo and you find that, and you thrombolize the patient, echo continues to show 35%, but maybe at 4 weeks, 6 weeks, because 40 days would be roughly about 42 days, which is about 6 weeks. At the end of 6 weeks, if your ejection fraction improves, then you have no business to put a person on ICD. As far as your patient is concerned, check for his blood pressure lying down and standing, one. If not, check for his hypersensitivity of carotid arteries. And number 3, is he a diabetic?
No, sir, he's non-diabetic.
What is his age?
He's 68 and he's not from India. He's from Caribbean. He's living in India, but he's from Caribbean islands.
So check for his carotid artery hypersensitivity syndrome. Check for his orthostatic hypotension and get an MRI, because these could be complex partial seizures also.
We've got an EEG done, that is normal. We've checked the postural hypotension also. There is no postural fall as such. We have done it a
Complex
repeated
partial
times.
seizures, several times EEG
EEG
will
may
be
be
normal.
normal.
And that's the reason why MRI should be done, to see if there is any organic lesion for it.
That's not there. That's already done, sir.
That's fine. Then he doesn't have any indication for PPI.
Thank you.
Unless we are missing something on the echo or on Holter or ELR. ELR is a reasonable choice for him.
It's not available over there, so he will have to come to Delhi now after COVID. Once it settles, then he will come. So thank you very much. I had one more point, was that if we have a old echo available, which has been done in 3 months of a patient, and there has been no diastolic dysfunction in that echo, and now we have a fresh, in which we may have a clinical circumstances where the patient may have a chest pain and there is an onset of this diastolic dysfunction. How much liability would you give to this diastolic dysfunction at this point of our time, as far as acute coronary event is concerned?
0.
Mm-hmm.
Your indications of taking the person for thrombolysis or for PCI are only dependent on ECG.
ECG.
Full stop.
Right. Thank you, sir.
Anybody else like to ask a question?
Good evening, sir. Myself Pranam. I want to ask one question, sir. While doing the pre-op echoes, most of the times I got that key when the patient's ejection fraction is very less, around 20-25%. I got confused about the global hypokinesia or only anterior wall hypokinesia is there, sir. Most of the times I got that difficulty. So how should we? Hello.
So global hypokinesia, regional wall motion abnormality, selective regional wall motion abnormality. You want to differentiate and cut thin because of what? You want to make a diagnosis of coronary artery disease versus dilated cardiomyopathy?
No, sir. Exactly. While doing the pre-op echo, there is no any history of acute incidence of coronary arteries, or just a pre-op echo is doing, and I got that EF is very low. But I felt sometimes that there is a due to tethering effect or some. I can't differentiate between the global hypokinesia or only anterior wall is hypokinetic. Some 10% cases I'm getting difficulty.
So in case there is any confusion of that sort, my suggestion is that you should go into short axis. And short axis will give you an answer whether the lateral wall is moving adequately or not, contracting adequately or not. So because lateral wall in 4-chamber is always a challenge. And that is the place why you want to make a differentiation. But whether you, and why do you want to cut it thin? My basic question was that you want to cut it thin because you want to segregate coronary artery disease from dilated cardiomyopathy. Is it the issue?
No, sir. In most of the times, in case of dilated cardiomyopathy, the other things that should be there. That is dilated left ventricle and dilated ELA is also there, or all four chambers has to be dilated. But
So
most of the size of the LV
Pranav,
was, yes sir.
I have, except in very acute episodes, LV is invariably and always dilated when the ejection fraction is 20 to 25%. That is how it kind of um, remodels. This is exactly what is remodeling, that it starts ballooning the moment it starts to fail. So, and also see the ECG, because several times you will find ECG would be having an undercurrent left bundle branch block, in which you have, just give me a minute. Sir, you take over the question.
I'll take over. What exactly I like to contribute couple of things in this particular scenario. Important issue is, look, if you are able to see a wall motion abnormality, what you want to say, whether it is ischemic versus dilated. First of your question is like LA, LV, four chamber dilatation is there. Presence of four chamber dilatation does not always tell you that this is ischemic or dilated. If you're having all four chamber, there are high chances of having a dilated cardiomyopathy, but it can happen in ischemic cardiomyopathies also. Variety of ischemic and dilated cardiomyopathy, they can have various kind of a presentation like dilated LA, normal, dilated LV, normal LA, normal RV, normal RA, and normal IEC. That is first option. Second option is dilated LV, dilated LA, normal RV, normal RA. Third option is dilated LV, dilated LA, dilated RV, normal RA. And fourth option is all of them are dilated and hypokinetic. So variations are positive in all, whether it's dilated versus ischemic. We should understand that important issue. That is the reason why a 25% patient ejection fraction, one person, he keeps around moving everywhere in the world because his LA, RA, RV and IVC, they are normal. On the other hand, the person who has got all four chamber involvement and raised LA pressure and RA pressure, he's bedridden. And there's something in between where RA pressures are high, but RV are normal, though he's limited exercise is possible. That's one issue. Second issue is, if you really want to differentiate, is you can do a simple tissue Doppler imaging across all annulus. You put a sample volume at septal annuli, take a S wave of TDI. Lateral annuli, S wave of TDI. Anterior annuli in two chamber view, inferior wall in two chamber view, S wave, anterior, inferior. If it's a dilated cardiomyopathy, all annuli will be uniformly reduced. And if it is ischemic, you might find a variations, like some will say 6, other will say 4, and that kind of variation will be there. Otherwise, 5 to 6 would be the normal uniformly reduced values would be there. Last, I'll give you an answer, like whenever we have these dilated or ischemic cardiomyopathies, if you want to do echocardiography, you do a low dose dobutamine. That will start differentiating. Obviously, when the patient has settled down, that will start differentiating between ischemic versus dilated cardiomyopathy. If not, all these people should be subjected to coronary angiogram to look for any interventionable lesion. Because if it's a ischemic myocardium, which Dr. Samir was trying to tell you, if it's a ischemic myocardium, if we is viable and if we revascularize it, that's going to show much better result versus a non-ischemic or normal coronaries myocardium. That's how we treat with these kind of patients. I hope I'm able to give you the answer.
Yes sir, yes sir. Thank you very much sir. It was very good.
Samir, you like to add something to it?
No, you have adequately answered just about everything.
So anybody else like to ask something? Look, this is bread and butter of our services, but you should be very specific what you're going to talk about. I still always say, look at an ECG. If it's ST elevation, fair chances is we need a thrombolysis or intervention. If ST depression, there's no role for ST thrombolysis, there's only intervention. And if there's fresh onset LBB or RBB, the chances is that we have developed an ischemic insult and we need to sort out that what kind of ischemic insult is. Second important part, if you have an LBB alone suddenly develops, look, you cannot differentiate anterior wall MI then. How do you look at it? Go to echo. If his LVB is present, what will affect? LVB will affect only septum. If it's anterior wall MI with LVB, look at the anterior wall, because if it's anterior wall MI, anterior wall will also be hypokinetic. Not only the septum, which will show jerky motions. If it's pure LVB without any anterior wall MIs, in that case, anterior wall would be normally contracting and septum will show jerky motions. That's how we can differentiate them. But final answer always come with intervention. And at this point, I like to say, whatever your caliber is, whatever you're doing, don't let these patients having the benefit of interventions. Don't hold them if they require interventions. Because that's normally our thing is, look, intervention नहीं भेजना. जहाँ जरूरत है उसको वहाँ जरूर भेजना है. And that you can only do when you are very dogmatic in selecting. Look, this is what, this is what. I hope that's what is clear to you. Echo in coronary artery disease. Dr. Samir, please add something.
No, I'm very comfortable.
So anybody else before we close down this session? And we are always open to these questions anytime later on subsequently. You should understand very clearly what is echo in coronary artery disease. And Dr. Samir has taken excellently well. He has covered practically everything. I just wanted to add one more thing. Now today CIMT alone is not the only culprit. If you happen to see a small plaque at the origin of bifurcation of carotid vessel, they are more specific than CIMT alone now. Dr. Srinath, you want to say something? Shrikant?
Yes, sir. Is there any treatment for carotid artery hypersensitivity, sir?
Avoid the hypersensitivity.
Yes, sir.
How do we avoid the hypersensitivity for my knowledge?
So basically you ask them not to wear collared shirts, ask them not to wear tie, you ask them not to, and if need be, put them in a
Neck collars.
Neck collars so that they don't.
And not to visit a barber.
That's
Okay.
correct.
And barbers have got a habit of rotating your neck to a large extent.
Okay, sir. Thank you, sir.
Anybody else? Dr. Atul Dalal, Dr. Prakash, Dr. Maninder, Dr. Ajit, Dr. Ashish. So all of you are well conversant today with the echo in coronary artery disease.
Hello, sir. One
Anand,
question
go
is
ahead.
there not
Yeah.
related to the today's lecture, sir.
No
Should I
problem.
ask it?
Anything.
So one patient was there, young patient was there. He is having the restrictive cardiomyopathy. What I have read, what I have knowledge about that, in restrictive myocardiopathy, there is a diastolic dysfunction is there. But he was having, yes, sir. But he was having systolic dysfunction also. I have not understand that part, sir. He was EF having 30-35% only.
You will answer this question.
What is the etiology of diastolic?
So they have done the MRI and they have just said that it will query tuberculous granulomatous possibility of that, sir.
So that is exactly what I was saying, that possibly it is not tubercular and it is sarcoidosis. Whenever there is a sarcoidosis, there is an element of restriction which is there in diastole, certainly, but there is a different problem in the myocardium as well. So before you subject the patient only for anti-tubercular, at some point of time, you must get the ACE levels done, angiotensin converting enzyme levels done. Prove that it is not this thing. And if you can get a node from somewhere, then pick up a biopsy, because most of the times it is, just understand, if it is myocardium which gets restricted, myocardium is a muscle which bothers in both systole and diastole. And there is no restrictive cardiomyopathy which will continue with only restriction during diastole and not have a systolic dysfunction at some point of time or not. It is how it happens. What begins first? Diastolic dysfunction will lead to systolic dysfunction. Systolic dysfunction is almost always associated with diastolic dysfunction. Diastole is a very, very dynamic process. It is a calcium consuming process. And that is the reason why diastole goes first. But it is not that if it is a diastolic dysfunction, which is seen more often than not in restrictive cardiomyopathy, systole will not be involved. Amyloidosis, classical diastolic dysfunction, classical restrictive cardiomyopathy, but at some point of time LV starts failing, systolic functions.
Samir, will not be a cardiac MRI would be helpful in this situation for him?
He has already had it.
I already had it, okay.
He has already had a cardiac MRI where they have picked up granulometers and they have made a etiological diagnosis of tuberculosis.
And most likely is a sarcoidosis.
I'm doubting the diagnosis of tuberculosis because most of the times when we have seen a diagnosis of tuberculosis, yes, we have had some tubercular myocarditis, but several times we have had.
And there's some selective sign in cardiac MRI to look for sarcoidosis. I've just skipped off my mind, like if you do a T2 scan for sarcoidosis,
So,
you selective idea.
Yeah, so LG is the thing which kind of can differentiate these things, but to be confirmation, you need tissue or ACE levels. ACE levels, because several times you will not be able to get nodes,
Right.
or you will have to go videoscopically to pick up the nodes. So best is to get the ACE levels to begin with.
In fact, sarcoidosis number of times is more seen than expected. You know, like we cannot pinpoint them, but they're seen more commonly. And only problem with us is we can't make a proper diagnosis. Go ahead, please.
Hello, sir. I had a query. Suppose there is a patient who has a history of history which is compatible with MI some 2 months back, and he comes for angiogram and it shows the blockade. So should he be undergo intervention, or prior to that he should be having viability testing?
There is no scope of doing an intervention if you are not convinced that there is viability. You're not treating blockages. What are you treating? You're treating effect of blockages. If the effect of blockage is ischemia, then you relieve the blockage. If the blockage is 95%, and if you are having collaterals, which is not leading to ischemia in that segment, you have no business to intervene. So what are you treating? You are treating not anatomy, you are treating physiology. So you have to document ischemia. How do you document ischemia? Classical angina. If you have it, you are convinced that it is ischemia. If the person doesn't have angina, then you go for further testing with debutamen stress echoes, you go for thallium scans, you go for PET scan, you go for MRI, but do not subject a person to revascularization unless you are convinced that it's a viable tissue.
I'll just add one thing Samir has already said very clearly. If there is no sign for a chest pain or heaviness with exertion, and that is the most important classical diagnostic test for any viability. Forget about all tests. I can quote an example. A person came down all the way from Calcutta to get his 25% ejection fraction to get his evaluation for combo device. Absolutely all parameter, tissue Doppler parameter were correct. He was 20% ejection fraction. He went to the toilet, and when he came back from a toilet, he was sitting on a Hindi toilet, and when he came back, he was having a hand on his chest. Look, that changed the complete scenario for that patient in our lab. We did a dobutamine echo for that patient, and dobutamine echo came out to be positive. The guy who came for a combo device, we advised for cardiac surgery, triple vessel disease. Finally, CAG was triple vessel disease, and he was done a bypass surgery. 20% ejection fraction became almost 40 plus within 3 to 6 months. So, quest is spend time with the subject. Don't just be in a hurry. Normal scan, forget about it. But wherever the echo is really needed, there you need to spend time with the patients. Give them a time. Look at come at this time when you're relatively free. Just don't hurriedly do at that moment. Or do something and tell them, look, some excuse you can have. Take this, come after 24 hours. And one recent ischemia trial has been published. You must read that ischemia trial now.
Ischemia trial is a game changer.
And you can only dogmatically say something when you are well read about that topic. Anybody else?
Sir, what should be the sequence of echo examination if ECG is pointing to some territory, like V1, V2, like the anterior?
Sorry, come again. What is the question?
What should be the sequence of echo examination if ECG is pointing to some territory of the heart?
Your
What is your
sequence continues to be the same. You're talking what views will you take? How will you take?
yes, sir.
Same parasternal short axis, 4-chamber and 2-chamber. Those, because you have to see for the wall motion first. You have to see for valvular. So, sequence doesn't change with etiology. You have to do just about everything in that.
I'll send you a lecture, like a recorded lecture link, which you can see where we have recorded this, how to sequentially go for echo evaluations. All right, if any no more questions, let's close down and pay thanks to Samir for his excellent interactive presentation today. That's what we were really looking forward, Samir. And I hope they have learned a lot as far as echo in coronary disease is concerned. And thank you, Samir, for all your
Thank you, sir. Thank you, sir.
everything. And thank you, everybody, for part of this particular program. Grateful. See you then next.
Okay.